Crohn disease Eric J. Mao, MD Samir A. Shah, MD, FACG, FASTG, AGAF Basics Description A chronic, relapsing inflammatory gastrointestinal, GI, tract disorder, most commonly involving the terminal ileum, 80%. Hallmark features of Crohn disease, CD, transmural inflammation that can result in fibrotic strictures, fistulae, fissures, or abscesses non-caseating granulomas, 30%, skip lesions, segmental disease distribution interspersed with normal mucosa, can also be continuous, mimicking ulcerative colitis, UC, diverse presentations, ileitis, 1/3, ileocolitis, 1/3, isolated colitis, 1/3, early disease ulcerations, focal lesions with surrounding edema, resembling aphthous ulcers perianal disease, pain, anal fissures, perirectal abscess, may precede intestinal disease. May present as wasting illness or anorexia developed disease mucosal cobblestoning, luminal stenosis, creeping fat, fissures between mucosal folds result in strictures or fistulae. Epidemiology incidence 3 to 20 cases per 100,000 person years in North America, incidence rising globally by modal age distribution, predominant age is 15 to 30 years, with a second smaller peak at 50 to 80 years. Women slightly more affected than men, increased incidence in northern climates, increased risk in whites versus non-whites, 2 to 5-fold increased risk in Ashkenazi Jews, 3 to 5-fold prevalence 247 cases per 100,000 persons. Etiology and pathophysiology. General, clinical manifestations result from activation of inflammatory cells and subsequent tissue injury. Mechanism of diarrhea, excess fluid secretion and impaired absorption, bile salt malabsorption in inflamed ileum, steatorrhea, bacterial overgrowth. Multifactorial, genetics, environmental triggers, commensal microbial antigens, and immunologic abnormalities result in inflammation and tissue injury. Genetics. 15% of CD patients have a first-degree relative with inflammatory bowel disease, IBD. First-degree relative of an IBD patient has 3 to 30-fold increased risk of developing IBD by age 28 years, greater than 200 genes associated with IBD, greater than 71 CD genes. Mutations and susceptibility. Loci. Ileal CD, IBD1 gene, NOD2 early onset CD, age less than or equal to 15 years 5q3133, IBD5, 21q22, and 20q13. Extra-intestinal manifestations of CD, mutations in HLA-A2, HLA-DR1, HLA-DQW5. Others, IL-10, IL-23 receptors, ATG16L1, IRGM-associated genetic syndromes, Turner and Hermansky-Pudlik syndromes, glycogen storage disease. Type 1b risk factors. Environmental factors. Cigarette smoking doubles the risk of CD, tobacco cessation reduces flares and relapses. Dietary factors, higher incidence if diet high in refined sugars, animal fat, protein, meat, fish, Salmonella or Campylobacter increases risk of developing IBD. Clostridioides difficile infection may trigger flare and make treatment more difficult. Commonly associated conditions. Extra-intestinal manifestations. Arthritis, 20% seronegative, small and large joints, ankylosing spondylitis, AS, and sacroiliitis, SI, skin disorders, 10% erythema nodosum, pyoderma gangrenosum, psoriasis. Ocular disease, 5% uveitis, iritis, episcleritis. Kidney stones, calcium oxalate stones, from steatorrhea and diarrhea, or uric acid stones, from dehydration and metabolic acidosis, fat-soluble vitamin deficiency, A, D, E, K, osteopenia and osteoporosis, hypocalcemia. Hypercoagulability, venous thromboembolism. Prophylaxis essential in hospitalized patients. Gallstones, cholesterol stones resulting from impaired bile acid reabsorption. Primary sclerosing cholangitis, 5% more common in men with UC, asymptomatic, elevated alkaline phosphatase as marker, increased colon cancer risk. Annual colonoscopy, autoimmune hemolytic anemia conditions associated with increased disease activity, peripheral arthropathy, not SI and AS. Episcleritis, not uveitis, SI, AS, and uveitis are associated with HLA-B27. Oral aphthous ulcers and erythema nodosum. Other complications: GI bleed, toxic megacolon, bowel perforation, peritonitis, malignancy, rectovaginal fistula. Diagnosis: history. Hallmarks: fatigue, fever, weight loss, prolonged diarrhea, perianal disease, crampy abdominal pain, +/bleeding. Children may present with failure to thrive. Factors exacerbating CD: concurrent infection, smoking, nonsteroidal anti-inflammatory drugs, antibiotics, stress. Physical exam. Presentation varies with location of disease. General signs of sepsis/disease activity: fever, tachycardia, hypotension or wasting/malnutrition, abdominal, focal or diffuse tenderness, distension, rebound/guarding, rectal bleeding, palpable mass. Perianal, fistulae, fissures. Skin, erythema nodosum, psoriasis. Differential diagnosis: acute, severe abdominal pain, perforated viscous, pancreatitis, appendicitis, diverticulitis, bowel obstruction, kidney stones, ovarian torsion. Chronic diarrhea with crampy pain, colitis like UC, radiation. Colitis, infection, drugs, ischemia, microscopic colitis, IBD, celiac disease, malignancy, lymphoma, carcinoma, carcinoid wasting illness, malabsorption, malignancy. Diagnostic tests and interpretation: initial tests, lab, imaging, complete blood count, CBC, serum chemistries, liver function tests, LFTs, erythrocyte sedimentation rate, C-reactive protein, serum iron, vitamin B12, vitamin D25O, stool calprotectin if diarrhea, stool specimen for routine culture, C. difficile, and ova and parasites with severe flares, kidney, ureter, bladder. To rule out toxic megacolon, ileocolonoscopy provides the greatest diagnostic sensitivity and specificity. Biopsy: normal and abnormal mucosa. 1. See upper endoscopy for patients with upper GI signs or symptoms. 1. See signs of upper GI CD, antral narrowing, segmental stricturing, inflammatory mucosa. Small bowel, sensitivity of CT or magnetic resonance enterography, MRE, better than small bowel follow-through. MRE has no radiation exposure, important in younger patients. Capsule endoscopy allows small bowel visualization but no biopsy. 2a. Signs of small bowel disease: narrowed lumen with nodularity, string sign, cobblestone appearance, fistula and abscess formation, bowel loop separation, transmural inflammation, perianal disease, endoscopic ultrasound, EUS, or MRI. Pelvis with exam under anesthesia. Contraindications to endoscopy: perforated viscous, recent myocardial infarction, severe diverticulitis, toxic megacolon, or intolerance of bowel preparation. In most cases, unprepared limited sigmoidoscopy allows adequate visualization to assess severity, extent, aspirate stool for C. difficile, obtain biopsies to assess histologic severity, and exclude other disorders, e.g., cytomegalovirus, in colonic CD. Follow-up tests and special considerations: evidence of complications, stricture, obstructive signs, nausea, vomiting, pain, weight loss, diarrhea, or inability to pass gas/feces, abscess/inflammatory mass, localized abdominal peritonitis with fever and abdominal pain. Diffuse peritonitis suggests perforation or abscess rupture, may be masked by steroids, opiates. Fistula. Enteroenteric, asymptomatic or apalpable, commonly indolent, abdominal mass. Enterovesical, pneumaturia, recurrent urinary tract infection. Retroperitoneal, psoas abscess, ureteral obstruction. Enterovaginal, vaginal passage of gas or feces, clear, non-feculent drainage from ileal fistula, may be misdiagnosed as primary vaginal infection, Diagnostic procedures / other. How to distinguish CD from UC. CD. Small bowel disease, rectal sparing, skip lesions, granulomas, perianal disease, and / or fistulae. No gross bleeding, right lower quadrant pain is common. UC. Continuous involvement including the rectum, loss of vascularity, friable tissue, left lower quadrant pain, typically only affects colon, rectal bleeding. Common alert. CD can mimic UC with continuous bowel involvement. 10–15% of cases are difficult to differentiate. Treatment. Disease activity, Crohn disease activity index, CDAI, asymptomatic, spontaneous, after medical / surgical intervention, or while on steroids, CDAI 150, mild to moderate. CD, ambulatory patients able to tolerate PO intake without dehydration, obstruction, or 10% weight loss, no abdominal tenderness, toxicity, or mass, CDAI 150 to 220, moderate to severe. CD, patients who have failed initial treatment or who continue to have mild symptoms such as fever, weight loss, and abdominal pain, CDAI 220 to 450, severe, persistent symptoms despite therapy with glucocorticoids and / or biologics or fulminant disease, peritonitis, cachexia, intestinal obstruction, abscess, CDAI greater than 450, CD. Risk stratification for rapidly progressive disease, risk factors for moderate / high-risk disease, age at diagnosis 30 years, extensive anatomic involvement, perianal or severe rectal disease, deep ulcers, prior surgical resection, stricturing, and / or penetrating behavior. Low-risk disease. Budesonide or prednisone taper with or without immunomodulator. Moderate / high-risk disease, biologic monotherapy or biologic combination therapy with immunomodulator. General measures. Oral lesions, triamcinolone acetonide in benzocaine and carboxymethylcellulose or topical sucralfate for aphthous ulcers, cheilitis, and / or granulomatous sialadenitis. Gastroduodenal. CD, no clinical trials. Case reports show success of anti-TNF therapies, symptomatic relief possible from proton pump inhibitors, H2 receptor blockers, and / or sucralfate ileitis, supplemental fat-soluble vitamins, iron, vitamin B12, folate, and calcium may be necessary. Treatment. Toxicity, pancreatitis, bone marrow toxicity, lymphoma, non-melanoma and melanoma. Skin cancer, infections, tuberculosis, TB, histoplasmosis, others, malignancy. Medication. First line asymptomatic with minimal endoscopic disease, observation alone. Mild. CD. Mesalamine should not be used to treat active CD. 1. A. Antibiotics not more effective than placebo. 1. C. Induction, controlled ileal release. Budesonide, 9 mg/day for 8 to 16 weeks and then discontinued over 2 to 4 week taper, for distal ileum and / or right colon involvement. 3. A tapering dose of prednisone. Maintenance, stop therapy and observe immunomodulator therapy. Adjunctive therapy, antidiarrheals, loperamide, bile acid binding resin, cholestyramine 4 to 12 g/day, probiotics, either alone or in combination may reduce inflammation / symptoms in acute CD, moderate to severe. CD. Induction, biologic as initial induction agent to avoid corticosteroids, controlled release. Budesonide, for isolated, moderate ileitis, or prednisone 40 to 60 mg/day for short-term to alleviate symptoms. 1. C. Maintenance, no role for mesalamine. If steroids required for induction, use biologic. 3. B and / or immunomodulator. 3. B except for budesonide, do not use steroids for maintenance. 1. A. Immunomodulators, thiopurines, azathioprine or 6-mercaptopurine, 6 mp, for maintenance but not induction. 1. C. Check thiopurine methyltransferase, TPMT, and LFTs prior to initiation, CBC/LFTs Q23MO methotrexate, SC or IM effective for induction and maintenance of steroid-dependent CD. 1. C. Take with folic acid 1 mg/day, Follow LFT, CBC. Anti-TNF, infliximab, adalimumab, certolizumab pegol for induction and maintenance of remission. 1. A check for evidence of TB and hepatitis B virus, HBV, infection prior to initiation of anti-TNF therapy. Avoid live vaccines. Monitoring, CBC, LFT, drug levels combination therapy, anti-TNF and immunomodulator. Immunomodulator can be added as adjunctive therapy or to reduce immunogenicity against biologic. Azathioprine and infliximab is more effective than either alone if no previous therapy with either. Rare complication, hepatosplenic T-cell lymphoma, fatal, seen in young males, with thiopurines only anti-adhesion molecules, prevent inflammatory cells from entering GI tract. Vitalizumab, gut selective, used in anti-TNF failures or anti-TNF naive patients as induction and maintenance, given for no risk of progressive multifocal leukoencephalopathy, PML, 1, B. Natalizumab, non-gut selective, used for induction and maintenance, 1, B, PML risk, 1/1,000, can minimize risk by testing for John Cunningham, JC, virus antibody, avoid risk of PML now with vitalizumab. Anti-IL-12/IL-23 monoclonal antibody, ustekinumab efficacious in induction and maintenance of remission in anti-TNF naive and anti-TNF failures. Excellent safety profile, monitor CBC and LFT's therapeutic drug monitoring, optimize biologics to avoid side effects. Measure trough levels of drug, and if drug not present, assess for antibody to the drug. If low or absent drug level and no antibodies, increase dose or frequency. If no drugs and high antibody levels, switch to a different agent with same or different mechanism. If drug present and no antibodies with active disease, switch to an agent with different mechanism. 4. C. New/investigational therapies, JAK1 kinase selective inhibitor, anti-IL-23 agents, and sphingosine 1-phosphate receptor modulator. Ongoing care follow-up recommendations. Patient monitoring. Vaccinations. Check titers, avoid live vaccines, measles, mumps, and rubella, varicella, Zostavax, in patients on immunosuppressive therapy, steroids, 6-MP, azathioprine, methotrexate, or biologics. Regardless of immunosuppression, human papillomavirus, influenza, pneumococcal, meningococcal, hepatitis A, B, Tdap, Shingrix for those 50 years or older. Cancer prevention. Colonoscopy with targeted biopsies every 1 to 3 years after 8 to 10 years of CD with colonic involvement. Consider chromoendoscopy if available. 5. C. Annual Pap smears if immunocompromised. Annual skin exam. Bone health. Calcium and vitamin D supplementation with each course of corticosteroids or if vitamin D deficient. Bone density assessment if previous steroid use. Maternal history of osteoporosis, malnourished, amenorrheic, postmenopausal patient education. Crohn's and Colitis Foundation, 800-932-2423, https://www.crohnscolitisfoundation.org. Complications. Peritonitis, bowel rest and antibiotic therapy, 7 to 10 days of parenteral antibiotics, followed by 2 to 4 week course of post-ciprofloxacin and metronidazole. Surgery as indicated. Consider holding steroids which masks sepsis. Abscess, antibiotics, percutaneous drainage, or surgery with resection of affected segments. Small bowel obstruction, for hydration, nasogastric, NG, tube for decompression, total. Parenteral nutrition, TPN, for malnutrition, resolution typically in 24 to 48 hours, surgery for non-responders.